Sure. So I work with Heidi Russell doing outcomes research, and what we looked at were all of our children who died at Texas Children's Hospital who either had a malignancy, bone marrow failure syndrome, or a histiocytic disorder. And we took about 7 years of patients, and we found that we had 419 patients, and we excluded those who didn't meet our diagnosis criteria and wound up with 379 patients. And we looked at the circumstances in which they died. So some of the things that we looked at where they died, if they had a DNR, what disease status they were in, so if they had active disease, how many times they've relapsed, if they've relapsed. And we also looked at if they died from disease-related mortality or if they had an infection, sort of ideas. And what we found is that about 57% of our children do die in our hospital, so they're inpatient deaths, and they either die in our main hospital or one of our satellite campuses. Occasionally they'll go to an outside hospital, particularly if they're from a different state and they've come to us for treatment. And then the remaining of our children actually die at home with either inpatient hospice, we consider that an out-of-hospital location, or at home with home hospice. And we found out two sort of striking things that we hadn't expected to find out from our study. One is that there's a strong component of race, ethnicity that tend to factor into where children die. So when we look, we discovered even when you're controlling for disease or you're controlling for language, that children who are either African American or Hispanic are significantly more likely to die inpatient than their counterparts who are not African American or Hispanic. And the other part that we found is that when we're usually talking about this topic, one thing that we want to talk about is the kids who are multiply relapsed or refractory. That's typically how we think about children with cancer when they die. They're dying from disease, and we've tried everything that we could, and despite our best efforts, they die. But we also have a smaller subset of our patients, about a quarter of our patients, who actually die, without being multiply relapsed or refractory. And those are kids who are sometimes in upfront therapy, or kids who are actually cured of their initial disease and continuing therapy, or they're, well off therapy. And those stories, we certainly think need to be heard. And doing the in-depth chart review that we were able to do, we're able to look a little bit more into those circumstances to sort of validate, that children oftentimes do die in the ICU and when they're in these phases of care, and that's a very appropriate place for them to die. So, the important thing that we found out is that, it does matter, is what we're finding out. We don't know if it matters from more of a cultural perspective. It also could be a resource perspective, but the important thing is just to realize that it does make a difference what race your patient is and their location of death, and to have those conversations with them and keeping a very culturally sensitive conversation with the family to try to figure out where they want to die. So the part that we want to get across is, just because we found out that you're more likely to die inpatient doesn't make it wrong that that's where you're dying, but we want to make sure that all families, regardless of their race or ethnicity, actually have the option of dying where they feel is most appropriate for their child.